I welcome him here and hopefully first oncology and field and metastatic. He will be on Dr. Smith. This subject, please. CRPC has been docetaxel. However, since the year 2010, several treatments have shown a survival benefit in patients. But despite numerous options, impact on survival is less than optimal. There are limited data, especially regarding the guidance to how to sequence these treatments optimally. And now, since many of the treatments are being used in the hormone sensitive setting, metastatic setting, so it becomes a challenge how you will sequence this subsequent to them being progressing from the sensitive sphere. Now, recently, several studies have also begun to show several predictive factors, and then certain new therapies have come on the and though it is for a limited group of patients, but it is at least a step forward. Next slide. So first, let us, how do we define CRPC? Well, there are several controversies regarding the first one, that is, how do you define PSA only progression? As you can see that the prostate cancer working group 3 has mentioned this, and this used in clinical trials, that more than 25% rise from the nadir or more than 2 nanogram per ml. And the European Association of Urologists have said 2 consecutive value rise above zero point 0.2 nanogram per ml. Then the development of new metastasis or progression of existing metastasis, and all of the above when the patient is on androgen deprivation therapy and the serum testosterone level is less than 50 nanogram per ml. Next slide. So, what are the mechanisms by which this castration resistance develops? Well, it is thought that, to very simply put it, it's quite via the androgen dependent and independent pathways. So, you might have mutations or amplifications in the androgen receptor itself, or alteration in survival by bypassing the androgen receptor. Next slide. So, if you look at the development and the approval of the drugs, though it began in the 1940s to 2004, it was almost static, hardly any progress made during that period. And then in 2004, it was docetaxel, which was found to be better than mitoxantrone and became the standard of care for this subset of patients. And then you had the bone modifying agent also being introduced. And then as the years went by, you had the sipuleucel T, then abiraterone coming in, followed by cabazitaxel, enzalutamide, and then of course you had the radium 223 and abiraterone. So abiraterone was one of the last entrants in this sphere. And since the year 2017, you have 2 more drugs, though for, as I said, a very limited number of patients, but they're extremely important. One being the immune checkpoint inhibitor pembrolizumab, and the other being the PARP inhibitor, olaparib and rucaparib. Next slide. So, what about the workup of these patients? So, most of the guidelines mentioned imaging, CT scan, chest, abdomen, pelvis, bone scan. Of course, there is a big question mark about the PSMA PET CT. Then come the biochemical parameters, and today it is mandatory to have germline genetic testing, that is MLH1, MSH2, MSH6, PMS2 for the Lynch syndrome, the ATM, the BRCA mutations, and also other genes which are related to the DNA repair mechanism. Then, of course, you have the next generation sequencing, where several targetable abnormalities at least for the future, are important. And then, of course, the MSI and this particular fusion gene called the NTRK gene, because although the incidence is just less than about 1%, we have very effective drugs for this subset of the population. Next slide. Now, when we come across such a patient, there are various clinical considerations in deciding the therapy. Most important being the performance status of the patient, his comorbidities. Most important also today, because as I said, many of the drugs that we use here have always already been used in the sensitive setting. So we need to see what prior treatment has been given and what is the interval between the prior treatment and the progression. The symptoms are important. The extent of disease, whether it's bone only versus soft tissue or only lymph nodes or visceral disease. Then, of course, once you discuss all the options, the patient preference is extremely important, as well as the cost of therapy. Next slide. So there are therapies for the non-metastatic CRPC where the PSA doubling time is less than 10 months. Now, if the PSA doubling time is more than 10 months, one could, and the patient has no symptoms, one could think of observing, but there's no straightforward guidelines on that issue. And then you have these very important studies of enzalutamide, apalutamide, and darolutamide. And what is important is they all belong to the same family, but this newer drugs have got less side effects, especially their penetration across the blood-brain barrier, and that is why the uncomfortable side effect of seizures is not seen with these new drugs. And then the last drug, of course, it's a tongue twister, darolutamide. It also has activity on the mutant androgen receptor. So I think this is why these new drugs have come in to reduce the side effects of the older drugs. Now, these were all used in patients who had just the PSA doubling, no metastatic disease. And as you can see on the right hand side, they showed very impressive results as far as survival and PFS was concerned, and with almost a 25 to 30% reduction in the risk of death. So I think very important in this setting. Next slide. Then there are several non-targeted therapies in this setting. I'm just enumerating them, but as I said, their use will entirely depend upon what the patient has had before and what is the time interval. So you've got abiraterone, enzalutamide. We know that the patients do very well if they're treatment naive, but suppose a patient has received one of these drugs in the sensitive setting and then they progress, then although the drug may be slightly effective, the next one, but the benefit is definitely less than what it would be in the naive setting. Then sipuleucel T has got its limitations, not available here, expensive, and for a very select group of patients who have had an indolent disease and very few sites of disease as well. Docetaxel is more for the aggressive disease. Cabazitaxel for those who do not respond to docetaxel and still require chemotherapy. And radium-223 is mainly for those who have got bone pains and bone lesions, though it has shown some survival benefit, but it is predominantly for patients who have no extra skeletal disease. Next slide. So the expanding role of abiraterone and enzalutamide when they were first introduced initially in this setting before they were taken to an earlier setting had shown overall survival benefit both in the pre and post chemotherapy settings. So they can be used in either setting with improved radiologic progression and quality of life. And they are well tolerated agents. So you have these studies and you can see that definitely there is a survival benefit in both the studies. Next slide. So how do we choose between these two? So basically, it would depend naturally on what are the comorbidities and like if there are liver function abnormalities, cardiac function, and diabetics, then definitely enzalutamide would be uh, preferred if there is a patient has diabetes and liver dysfunction. But if there are neurologic concerns, then definitely abiraterone would be preferred. Next slide. Then patient factors to be considered. Age is not necessarily a determinant. It actually depends upon the geriatric assessment of the patient's daily lifestyle, that you know that you're in a setting where quality of life matters. So we have to see the tolerance of the patient to all these all the treatments, and also the comorbidities. Next slide. So this is prior endocrine therapy and its impact on abiraterone efficacy. Next slide. You see that the patients have received androgen deprivation therapy, and clinical benefit is seen in both the 301 and 302 studies in terms of overall survival, progression-free survival, and PSA response. Next slide. So, what is the optimal second line therapy post and the androgen receptor targeted therapy used in the front line? Next slide. Well, there isn't any solid data. So, this is some of the data collected by the Canadian group for a rapid response report, and published in June 2019, not in the journal, but it's published online, where they looked at one randomized study, 12 non-randomized studies, and they compared the sequences. No doubt this is the retrospective data, but this is what we have, and this gives us some sort of a clue as to what might be better sequence. So if you have enzalutamide followed by abiraterone with plus enzalutamide versus abiraterone alone, there is no difference and there is more toxicity with the combination. So the combination should not be used. It should be just abiraterone. Then if you look at the sequence of enza followed by abiraterone or abiraterone followed by enza, then you can see that enza followed by abiraterone is better than the other way. Then if you look at whether after the androgen receptor targeted agent, you again use the other agent versus if you were to go to chemotherapy, then the chemotherapy does better than going to the second hormonal targeted therapy. Next slide. So this is one of the studies called the CARD study, which is a randomized open label study of cabazitaxel versus abiraterone or enzalutamide in the metastatic castration resistant prostate cancer. Next slide. And you can see that it was a multi-center randomized open label study enrolling patients between the years 2015 to 2018. The randomization was 1:1 with 129 and 126 patients on the experimental arm and the standard arm. The patients were metastatic CRPC who progressed within 12 months on prior alternative therapy, that is the androgen receptor targeted agent, before or after docetaxel. The stratification factors were the ECOG performance status and time to progression, whether between 6 months or 6 to 12 months. The primary endpoint was progression-free survival. The key secondary endpoints were overall survival, and there were other secondary endpoints. And you can see that the experimental arm was cabazitaxel and prednisolone with growth factor support versus either abiraterone or enzalutamide, depending on what prior treatment the patient had received. Next slide. You can see the mean duration of treatment was longer on the cabazitaxel arm. The median number of cycles were also more. That's because more patients progressed on the hormonal therapy arm than on the chemotherapy arm. Next slide. And if you look at the radiographic progression-free survival, then the study was met its endpoint with a hazard ratio of 0.54 and with a significant p-value of less than 0.001. Next slide. And also the overall survival was significantly better with the chemotherapy arm. Next slide. So you can see that if a patient has received hormonal therapy and docetaxel, then it's better to go for cabazitaxel than to go to the other hormonal therapy. Now coming to the newer therapies like genomic landscape of CRPC. As you can see that 90% harbor actionable molecular aberrations like the PIK3CA, BRAF, RAF, APC, beta-catenin. More than 20% of them harbor the DNA repair pathway aberrations either in BRCA1, 2 or the ATM gene, and 8 to 10% harbor pathologic germline mutations. Next slide. So this is an important study, profound study, as a result of which an approval was got for the olaparib in this patient population. So these were metastatic CRP with disease progression on prior hormonal therapies, and this more than any one of the therapies. And there was a cohort A and cohort B. The cohort A was the BRCA1, 2 and ATM mutations. Numbers were 245 and versus in a 2:1 randomization, other aberrations, alterations. So these were both these arms were randomized between olaparib and the physician's treatment of choice. And as you can see that the primary endpoint was again the radiographic progression-free survival, and there were several secondary endpoints. Next slide. So if you look at the efficacy, you can look at the olaparib and versus the in cohort A. You look at what was the physician's choice of treatment. So the median PFS was 7.39 months versus 3.55, and the progression free at 12 months was 28% versus 9.4%. So there was almost a 76% reduction in a chance of progression, which was highly significant. The overall response rate was 33.3% versus 2.3%, which again was very significant. And the median time to pain progression was not reached in the olaparib arm versus 9.92 months in the physician's choice. And even the overall survival showed a difference as opposed to the standard arm. And then if you look at the cohort B, also you see the difference in favor of the olaparib arm, although it is less as compared to cohort A, but even these patients benefited. Next slide. So the conclusions in this was that in patients with metastatic CRPC and alterations in the homologous recombination repair pathway with prior hormonal therapy, treatment with olaparib improved the PFS and overall response rate as opposed to physician's choice, despite a crossover. And safety was generally consistent with the known profile. So it is a positive study which is biomarker selected. Next slide. Please tell me if I'm running out of time. And this is another study where they try to combine the veliparib, which is another PARP inhibitor, along with abiraterone. Next slide. So these are very preliminary results. It shows that in those who have a recombinant repair pathway deficiency, the combination did better than abiraterone alone. Next slide. Next slide. So, no, just go back one slide, and this is my last slide. So if you see that now it is mandatory to do the germline genetic testing. The NCCN says that focuses on disease risk stratification and family history. Genetic familial assessment is important. An expert consensus meeting also said the take-home message is across guidelines, all men should undergo germline genetic testing, and if positive, they should be counseled, and they have the option of PARP inhibitor. And my last slide, please. Last slide. So patients who have one slide back, just one slide back, and that is to do with immune checkpoint inhibitors. So this is the Keynote 199 study which showed the activity of pembrolizumab monotherapy in this patient population. But it should be remembered that patients who have an MSI high, irrespective of the histology, do benefit from pembrolizumab. So MSI testing, which I had mentioned in my workup, is one of the other tests to be done in this patient population. And my last slide, please. So it is important to understand the mechanisms of resistance so we can go forward with better therapies for this patient population. Better sequencing is also to be understood. Newer therapies with PARP inhibitors and immunotherapy do show promise. And I think the day is not far when we may be able to personalize therapy for these patients. Thank you.
Thank you, Dr. Smriti. And I hope you will stay for Q&A answer. I'm mentioning, really grateful if you, Dr. Axel Marsberger. Many people will think that he's Alex, which I also thought in the beginning when I met him. And he is now Professor of Urology and Chairman of Department of Urology at University Hospital, Holstein Campus, Lübeck, Germany. He is trained in all aspects of open and endoscopic urology and has a particular interest in laparoscopy and robotic assisted surgery. He is a member and with the associates in the med.
Well, Satir, Dr. Raval, thanks a lot for inviting me. Thanks a lot for each other to base on the overlap disclosures. And Dr. Raval and myself, I think it's about 20 years ago, in Shiv Srivastava's lab, 2000, and you might recognize Judd Mall at the end. So I lost some hair since then, and Dr. Raval still looks the same. So it was a great time by then. I really have to conclude that I learned a lot from Dr. Raval, and this somehow set the basis on my interest, my academic interest, and especially on prostate cancer. We had great discussions, mostly at Indian restaurants, and I learned a lot from you, so thanks a lot. So the question, I was asked to focus on M0-CRPC and also discuss with you why I treat high-risk M0-CRPC. Then I have some data on MHSPC and why I think combination therapy makes sense. And I will conclude with some slides, a handful of slides on the current COVID situation and how we have dealt with it in Europe and Germany, and maybe some aspects we can discuss how we can all learn on and how to improve the situation in the countries. So intense treatment maintains health-related quality of life at a level similar to the general population when intensification of therapy in M0-CRPC is performed. You see in this patient journey that what Dr. Smutny alluded to in the previous talk, the extension of the metastasis-free survival for up to 2 years with those novel 3 substances is really good for the health-related quality of life. And we know that once it comes to CRPC, to metastatic CRPC, this equals poor survival, severe symptoms, and a reduction in health-related quality of life, and also a reduced survival of our men with advanced prostate cancer. up to 65% of patients with non-metastatic CRPC have the high-risk definition of CRPC, defined as PSA doubling time equal or less than 10 months and will develop metastasis within 16 months. This might not play such a big role in an 85-year-old gentleman. However, when we all know patients that are 55, 60 years and here, this really, really counts for quality of life and survival, as I show you in a couple minutes. Another aspect, and I think we have to look at costs with us, somehow very costly treatment options, but we know progression from non-metastatic CRPC to mCRPC really results in a proven substantial increase in healthcare costs, as shown down in this graph. Actually, I'm happy to share my slides after this event for your usage. And back in 2000, we have discussed at John Moll's institution this maximum androgen blockage, and that's about the time this data was published, 1995, on the combination of bicalutamide with ADT. And this combination was more like PSA cosmetics. It never showed an overall survival benefit, so that's why it's called somehow old school or vintage maximum androgen blockage. Now in 2020, starting from 2018, we have seen those three publications, the Spartan, the Prosper, and the Aramis trial for apalutamide, enzalutamide, and darolutamide, all published within the prestigious New England Journal of Medicine. And the previous speaker, Dr. Smrutny, just already alluded to, we saw a remarkable difference in MFS in all three trials, about 2 years MFS prolongation when you intensify treatment with novel hormonal treatment. Here, the head-to-head comparison, like the numbers, it's not one trial or three trials. I know it's not really scientifically too fair to show them, but all about 2 years MFS benefit. Also, the secondary endpoint time to PSA progression was statistically significant better for the combination arm. In Spartan with apalutamide, the trial also looked at the nice, I find it very interesting, secondary endpoint progression-free survival 2. And progression-free survival 2 takes into account, as you can see in the graph down below, that, for example, with apalutamide and ADT, median PFS is 40.5 months, and then also first-line mCRPC treatment. So it takes into account the subsequent therapy, and it showed that it makes sense to start early, at least for the trial apalutamide, which has been shown in the Spartan data. The health-related quality of life was not disturbed. There was no influence with regards to deterioration of the health-related quality of life, and in general, with regards to adverse events, all three substances were within the known side effect profiles we already know for the substances reported. The real-world evidence analysis, and I know also in India, PSMA PET plays a big role. And just today we saw PSMA yesterday discussion at the virtual EAU conference, where I'm sure some of you are also participating in parallel. It's a nice discussion, and really, it's my disclosure. I'm biased. I'm a big fan of the EAU meeting, and here a colleague of mine showed the Spartan-like population with negative conventional imaging, that when you perform PSMA imaging, you have more positive results, as one can imagine. However, this didn't result into this didn't have influence in the result. Very important, the secondary endpoint, overall survival. At the first publication, there was no statistical significance. However, now at the virtual ASCO, some weeks ago, we saw the updated analysis of all three trials. And I would like to take the next 5 minutes to summarize the findings. So the Aramis trial looking at darolutamide combination showed a 31% reduction and statistical significant risk for reduction in risk of death. So here we have a positive result. The same as for PROSPER, showing a 27% reduction in the risk of death. And last and fair but not least, the Spartan analysis of apalutamide, also an overall survival benefit in numbers 59 versus 73 months. So here the intense dual treatment at the beginning makes sense, and it translates in an overall survival benefit for the man with high risk M0 CRPC. So my summary for this topic, I would advise you to go along with the recommendation of the EAU by Nicolas Motet, offer APA, DARO, or ENSA in patients with M0 CRPC and a high risk of developing metastasis defined by PSA doubling time less or equal than 10 months to prolong time to metastasis. And this has to be updated also to prolong overall survival, as we've learned ASCO a month ago. So in conclusion, this subtopic, I think my reasons, I hope I made it clear why I treat high-risk M0 CRPC. It's an effective combination. We have relatively mild treatment side effects. We have an impact on the PSA, and this is what the patient sees initially, immediately. So he has no meds, but he wants to have the PSA down, maintains quality of life. And so this is, I think, something game-changing in non-metastatic CRPC. However, we have to discuss if there's really a disease as M0 CRPC, because as we know, when you do a PSMA PET in about 40% of the patients, you see metastatic sites, and then you have MCRPC, which would lead into a different treatment. Next part of my talk, I was asked to look at hormone-sensitive primary metastatic prostate cancer, also to look at low and high volume disease and what might be best. Here, I think when you want to define high and low, you have to see what is the definition and also what imaging you use. You have different and more meds when you use PSMA imaging. And according to the imaging and those charted criteria, low volume and high volume you see here are derived in an area and written and out of the Chris Sweeney charted trial in times where no PSMA PET was used. So we should use, when defining according to charted criteria, bone scan and conventional CT imaging. And as said, metastatic disease is a turning point in CRPC. Once it comes to metastatic CRPC, we have poor survival with increase of symptoms and reduction of health-related quality of life, and an average about a survival time of 3 years. So really, then we have somehow deadly disease. And the question is, we want to prevent non-metastatic CRPC to become CRPC. And we've seen the slide in a different style, but we've had just docetaxel 15 years ago, and now we have a very large armamentarium of substances to treat advanced and metastatic prostate cancer. And as you see here, the substances that were nicely presented by the previous speaker on MCRPC have been introduced in earlier setting, like in M0 CRPC, and also in the hormone-sensitive setting. And this is the topic I will be talking on the next 15 minutes. And the evidence network is really changing a lot. In last year's January, we had those data, ADT alone. Then we have the STAMPEDE data and Latitude on apalutamide combination. We had the docetaxel data out of Charted, the GITUC trial and STAMPEDE, and then the radiotherapy in oligometastatic disease showing a benefit. After ASCO last year, this evidence network even increased. We have seen the ARCHES and ENSAMET data on enzalutamide and the TITAN data on apalutamide, this time not in M0-CRPC, but in the situation of hormone-sensitive metastatic prostate cancer. And I was very honored to be within the steering committee of the TITAN trial, and my dear colleague Hirotsugo Umera from Japan has published last year's Japanese Society of Clinical Oncology an abstract, and he had a talk on a subgroup analysis out of the TITAN trial, looking at outcome in patients with high and low volume disease. So the all-comer population out of the TITAN trial, we know that it prolongs overall survival and reduces progression in hormone-sensitive prostate cancer. Here, the trial design, again, more than 1,000 patients were randomized to apalutamide and ADT versus placebo and ADT with the dual primary endpoints OS and radiographic progression-free survival. As said, the TITAN study included an all-comer patient population, so they were castrate sensitive, but they could have been treated locally. They could have had prior docetaxel, prior ADT for up to 6 months, and also local treatment. Here, the Japanese colleague looked at the low volume versus high volume according to charted definition. You see the numbers here, low volume, about 200 patients, and this resulted in a consistent overall survival benefit with apalutamide in high and low volume subgroups. So with the TITAN data, there is no need anymore to stratify according to high risk and high and low volume. And this was also seen in the radiographic progression-free survival curves for apalutamide in high and low volume subgroups. So the history of MHSPC treatment has also changed, and this is something that has changed within the last 5 years very much. And you see, last year was basically the year of MCSPC trials with TITAN, ARCHES, and ENSAMET. And this was translated in the most recent ESMO guidelines. And they were just published as a pre-proof last week of this group here, and showing that in hormone-sensitive or hormone-naive prostate cancer, a combination of ABI with ADT and PrET, or apalutamide, or docetaxel, or enzalutamide is the ESMO 2020 recommendation. So this is something what has led into international guidelines recommendation, and this has to be surely weighted on with the approval status of the substances, with the costs of the substances. But we can concur, I think, that ADT alone, as it has been 10 years ago, is not sufficient for treatment of metastatic castration-sensitive prostate cancer. And we have the latitude data, we have the TITAN data, we have ENSAMET and STAPEDE and CHARTED, all showing the same when looking at the hazard ratios for overall survival and radiographic progression-free survival. As said in TITAN, regardless of volume, there was a consistent benefit for the combination arm. And again, also for TITAN, and I show you this slide, it is also shown for enzalutamide and abiraterone, health-related quality of life was conserved and no difference between the placebo arm when intensification of the treatment was performed. So is there still a role for chemotherapy, and when does chemotherapy maybe fit better? And even though I'm a urologist, in Germany, urologists are allowed to give chemotherapy. We also give PEB for testicular cancer and gemcitabine, cisplatin in bladder cancer. So there's some experience in treating metastatic disease in urology as well. However, it's always very good to closely collaborate with your oncologist. And when just comparing the adverse events on latitude and abiraterone and CHARTED, and now within the last third of my talk, my job was to somehow promote also the chemotherapy. The grade 3 and 4 adverse events were less with chemotherapy than compared to abiraterone. One can say, hey, how can this be? I know chemotherapy is not that well tolerated. Yes, you are correct, you're right. But chemotherapy is done after 4.5 months. So if you have a patient that is desiring or wants a drug holiday or maybe cannot afford the cost, chemotherapy upfront might be the solution. Whereas ABI and PrED is a continuous treatment, and within the latitude, the well-controlled trial, surely all the adverse events were monitored by strict, well-done monitoring. And with regards to efficacy, at one point in the Stampede, the British trial, in 2012, both arms, standard of care and docetaxel compared to standard of care and abiraterone, were performed within the same time period. So they could somehow directly compare this data. And those curves are basically lying on each other. So you have very active treatment with abiraterone and not the side effects, acute side effects with chemotherapy, loss of hair, and what else comes along, as you basically well know, on chemotherapy. So you really have a good option with abiraterone for the man with primary metastatic prostate cancer. This has already been mentioned. I just would like to show this visual poster. I always like visual poster because it summarizes the already set and summarized CARD study trial where we also participated, showing that after sequence hormone treatment like abiraterone and docetaxel, what is the best third-line treatment? And it's surely not the other androgen signaling targeting inhibitor like ABI or ENSA. It is surely cabazitaxel according to the CARD trial. And so I think there is a role for chemotherapy definitely in metastatic prostate cancer, docetaxel, and in sequence third-line cabazitaxel for our man with metastatic CRPC. So I think for mCRPC, I can surely go along with the conclusion of my dear colleague just showing the Indian perspective on CRPC sequence. So I think either one we should start with, abiraterone or enzalutamide, really depending on the patient profile. Next step will be docetaxel. Here again, this is mCRPC sequence, not MHSPC. Then we have the option of cabazitaxel, and as already alluded to in the previous talk, since May this year we have rucaparib and olaparib as two PARP inhibitors FDA approved. And I think this approval will translate to Europe and other countries of the world where genetic alterations like BRCA1 or 2 are evident. This really makes sense according to the Titan trial, which has recently been published, and also the Profound trial, which you just saw. I think continuous ADT is important. Also think about osteoprotection. Don't forget denosumab or zoledronic acid. Think of calcium and vitamin D to protect the bone. And what's last line? We still have radium-223. We have evolving treatment options like lutetium PSMA PET, where we have seen data from ASCO also. Due to time limitations, I didn't pick it up now because we are still missing overall survival benefit here. And we have the VISION trial, which reads out end of this year on lutetium also. So more prospective data on lutetium is on the way. So something here to come, and the sequence will definitely change throughout the next years. So thanks again for the attention, for listening to my scientific part on prostate cancer and the new evidence we have. And now, last 5 minutes, COVID-19 and uro-oncology, what is the influence? And we can, when we compare the flu with COVID-19, there is a big difference, as you know. And in Germany, because we have very flat curve initially, everybody was complaining, why should we do a lockdown? It's not that serious. But I've been talking to a colleague at ASCO GU, and we discussed about, we're still there in San Francisco, and we discussed about COVID, because it just started in China at that time. And he said, well, if he would be constructing a very aggressive virus, he would probably design one like COVID, because it has a very high R0 number, so you spread it easy. Then you have a long incubation time. So when you are infected, it's up to 2 weeks, some say even 3 weeks, until you feel symptoms, but then all your friends, colleagues, family are infected. The hospitalization rate, even for younger people, is higher, up to 20%, and also the case fatality rate at this time, when this graph was written, so the evidence is updated very frequently, was about 3%. So what can we do? This was last month in February, and today we are sitting like this. And I think it's definitely important. And you are all aware who this gentleman are, Boris Johnson. At the beginning of this year, he was shaking hands and said, COVID is nothing, and just don't worry. Some weeks later, he was in intensive care. And he's not previously sick. He has no comorbidities. He is, I think, within his 50s, was just being father again. So then I think he really realized how serious this disease is, and I hope some other presidents in other countries will realize the same. So with oncology practice during COVID pandemic, also a lot of publications are out there, a lot published on that. And I think we have an impact on COVID on physicians and decision-making in patients with cancer. And we have seen, and I just picked this, and I think for this I use Twitter, and please feel free to follow me on Twitter, because I think in those unprecedented, those very difficult times, I think Twitter is a good source on somehow spreading the news. You really have to see whom you follow, not to fall into fake news. But here, a colleague from Russia published a recent Lancet publication showing that 20% mortality rate in COVID-19 positive patients undergoing surgery during the incubation period. So really some data. And as Dr. Raval already alluded on, I am involved in EU guidelines work, and also in the EU guidelines on robotic and single-site surgery. There's an update now from the resource center of the EAU, how to deal with laparoscopic surgery, especially when you have bowel perforation, that you have different suction devices in order, and what do you do in endourology treatment when you do a TURB for bladder cancer and you have a patient with an infected stool or infected urine. I mean, urine, it's going back and forth whether or not you have COVID in it, but you are in an OR where the patient gets intubated and possible aerosols will go through the room. So in Lübeck, we got prepared with designated OR rooms just for COVID patients. So far, we were lucky that the curve was very, very flat, that we had a maximum, I think, in a hospital with 1,000 beds. We have had a maximum of 30 patients with COVID, and now I think it's 3 patients in the whole hospital. So fortunately, the situation has changed, and hopefully also for your countries, it will change. And just very recently, I downloaded this yesterday. There's a publication on the EAU guidelines and how you treat, for example, metastatic hormone-sensitive prostate cancer in COVID-19 times. You can see, for example, what is the priority category. For example, clinical harm, very unlikely, postponed 6 months. Or clinical harm, deaths, very likely, postponed, and so on. So you have guidance according to the risk profile, and definitely it has to be weighted depending on the country and the city-specific situation. And also, it is set down at the asterisk avoid ADT combined with docetaxel. And in situations where you don't want to have the patient every 3 weeks in the hospital, abiraterone or enzalutamide or apalutamide might be the better option to give tablets. You can maybe even send by mail and don't have the patient in the hospital with a possible harm getting infected or spreading the disease within the hospital, the COVID disease. Also reconsider when you use abiraterone to reduce the dose of PrEP to 5 milligrams per day in case of severe COVID outbreak in the region. When it comes to metastatic CRPC, also the EAU guidelines has recently published this paper led by my dear friend and colleague Maria Ribal from Barcelona, also looking at the different situation with low, intermediate, and high priority. And this guidelines covers also bladder cancer. So I really advise you to download it. It's a good guide, but and for your clinic. And again, back down there, the asterisk chemotherapy should be avoided as much as possible, and systemic GCSF to avoid the number of visits. So, having said this, I would really like to thank you, the organizers, friends and guests, to listen to my talk. I have my Twitter and my Instagram handle here for the ones that want to follow me. Whenever you are in Germany, drop me an email or a tweet, and I'm happy to show you around Lübeck, my town, when COVID times have hopefully been over again, and we are all able to travel again. So thanks a lot for your attention, and I'm happy to discuss with you now.
Thank you, Axel, and that was really very informative, especially your talk on COVID also, which definitely give us some insight what is going to happen to us. Now we go to Q&A section. I have few questions, but before that, I would like to ask one question from you and same question to Dr. Smriti. Axel, my question is that right now we are seeing a lot of gene mutation derived treatment, and with that in prostate cancer, at what time you are doing genetic testing as NCCN has suggested, and what test you are doing in your country? Then I'll ask Dr. Smriti that what does she suggest for India?
So, Suthir, thanks for this very important question. So far, the situation isn't solved yet in Germany. Even in a very developed country like Germany, we cannot do like the genetic testing for all our patients, and it's not covered by the insurance as of yet because we don't have olaparib approved as of yet. What we do nowadays, NCCN guidelines recommends to do genetic counseling or testing once you have metastatic disease. Maybe this is a little bit too much, but I think you can consider it, and it's coming more and more in the clinic. Personally, in the German situation, we still have the Triton trial on rucaparib open. And also in my institution, I'm a country lead for Triton trial, second line rucaparib post abiraterone or enzalutamide failure. And for this, we are able to, for free, to do the genetic testing via Foundation 1 panel. So there's all the markers, ATM, BRCA1, BRCA1, FANC2, everything covered. However, when we have a patient where we are not able to include in a clinical trial, we cover the costs by a scientific budget, and we have a molecular tumor board in Lübeck where we meet every 6 weeks to discuss patients like the ones where we think as a urologist or oncologist we have a need for genetic counseling, and then we decide which markers make sense, and we have a panel in the pathology department that covers most important germline mutations or somatic mutations.
Thanks, Axel. Dr. Smriti, what do you suggest for India as on today? Dr. Smriti, you need to unmute. Is she there?
I think she's logged in, but not unmuted.
She probably. I don't think she's there, but anyway,
She's
when
there,
she joins.
she's there, but I think she's muted. So, Dr. Smriti?
Okay, then I'll go for next question to Excel, which is there from Dr. Mohammad Mahmood Hassan. He has asked what to do when testosterone more than 50 and PSA is rising in metastatic CA prostate and patient is on combined androgen deprivation therapy.
So on combined androgen, so the classical old school bicalutamide and ADT like Lupron, for example, yes, this is a happening problem. What I do, I redo the test with testosterone and I do the application of the Lupron or the ADT myself, because sometimes there is a reconstitution issue. You have to shake it depending on what you use. So really double check, and sometimes it's a problem that the study nurse didn't really apply it properly. So I think I would double check if it's properly given, then recheck the testosterone, maybe even consider switching the ADT form, looking at maybe GnRH blocker antagonist as an alternative option.
Or orchiectomy?
Orchiectomy, yes, orchiectomy as one of the last line options as well. Yeah. And then I think really depending on the clinical picture, if you have a non-metastatic disease, I think you are still fine. You have no threatening of the disease. But once you have rising PSA, per definition, you will have M0 CRPC, and then you would have the option to use one of the substances like darolutamide, enzalutamide, or apalutamide, as just discussed.
Thank you. Dr. Smriti, are you there? No.
Yeah.
She was co-host.
I'm there.
Yeah,
yes. Is there.
So I was asking the question which, did you hear when I asked Excel that?
No, I didn't hear.
Okay, I'll ask it again. So now, as you have shown in PROFOUND trial also, there are so many driver mutation and genetic alteration which are coming, and even in Germany they are not doing, they are just discussing, after discussing with molecular pathologists and all. What do you suggest in our country, and what facilities we have here in India to do these tests, and where should we do and when should we do?
Now, after the PROFOUND trial results, it is an approved drug. And for example, just a few months back, maybe about 4 months back, I have a patient who is running out of options, but we did his genetic testing. He had a family history as well. Now he has the ATM gene mutation, And
so in this testing, you did it on primary tissue, or you did
no, on the patient.
On the patient, okay.
So, now, for example, in ovarian cancer, we do it on the patient. If it is negative, we can do it on the tissue. So that may add a few more patients who may be eligible.
So on the patient, can you elaborate? In blood you do, or?
We do it on either the blood or the saliva, from the mouth. Yes.
So do you suggest this should be routinely done in our cases, or any after?
See, the only problem is the cost of olaparib. At the moment, even with the patient assistance, it's a very expensive drug. So we do the genetic testing from 2 points of view. One is for the patient, and then the implications for the family. So from both point of view, we ask for the genetic testing. Olaparib, very few can afford it, so that is a cost issue.
Okay, so next question is by Dr. Aditya Pradhan. He wants to ask Excel, what about combination therapy versus layering therapy in CRPC? Do you believe that you should have combination therapy, or one by one in CRPC?
So in CRPC, you mean combination like docetaxel and abiraterone together, or just ADT and abiraterone?
No, I think the.
Can I?
Yeah, Aditya, can you ask?
Yes, Axel, I wanted to inquire, what are your views on giving medication together? For example, docetaxel together. I'm aware Pete has got an arm which does this. So what are your views on layering, adding two drugs together versus sequentially using them?
So personally, and according to most evidence and guidelines, I think sequencing makes sense. And we've had some clinical trials, for example, the radium-223 combination, or the radium trial with abiraterone, which was negative, with increased side effects. The same for enzalutamide, so I would not combine. When looking at the data that is published so far, and also looking at hormone-sensitive disease, where we see the Enzamet data, where they had concurrent docetaxel, enzalutamide, and ADT with no benefit when combining all three. So I think at this point I would not combine. It hasn't been shown that it's an overall survival benefit. It just increases the financial toxicity. And I am happy to revise my opinion when we have new data, but it's an important point.
Okay, so next question is again related to genetic variant only, and any one of you can answer. And this is, does the genetic variant occurs during therapy, or since we find some patients respond well and suddenly they stop responding, or they are there right from the beginning? Dr. Smruti, you will like to take this question, or Axel?
Well, if you're talking of, the germline mutations, they're there from the beginning. But if you're talking of somatic mutations in the tumor itself, then naturally when you do an NGS, you do find that some of the mutations are occurring as a result of your therapy. Like even the ARV mutation which comes about, that is after treatment. So in most of the cancers, as we treat, somatic mutations occur.
Okay, there is another question that, okay, this is almost same related. I think this is a bit different. Can the genetics testing be done upfront so that the algorithm for management of prostate cancer can be decided in individual? And he's asking who have more than 15 years of life. So you are saying the genetic mutation, they don't change. So can it be done upfront? Like first you see the high risk prostate cancer or metastatic prostate cancer, you take tissue, and should it be done immediately at that time, or we can wait?
So if I can
yeah, please
drop
please
in
go.
here, I think it's good to do it immediately once you have metastatic prostate cancer. Then you can look, best is to have tissue better than liquid biopsy, because the results is more reliable, and on tissue you can also pick on the somatic alterations and not only germ cell. And once you don't have an alteration, it really makes sense to reinvestigate at a further course of the disease. So for example, after first or second line treatment of MCRPC, because as said by Dr. Smruti, the alterations in the somatic setting can change, and they increase up to 25% in the event of advanced metastatic CRPC. And then you might have a chance for treatment with olaparib or rucaparib. On the other hand, I found a very interesting abstract at ASCO and some years ago on bipolar androgen therapy. So for example, you give testosterone at a high dose. This is very experimental, yet somehow risky, but this is also under discussion. If the androgen receptor it's getting reactivated again, it is more, the cell cycle is more prone, for example, for abiraterone and enzalutamide treatment. And there was a nice abstract at ASCO just recently.
Yeah, I have seen that paper also. You are right. There's I think this is the last question, and since we have to discuss the case also.
Doctor, you allow one question?
Yes, Aditya.
So quick question here to Dr. Smruti or Dr. Axel. Patient of CRPC has been through multiple lines. You have got nothing left with you. Will you give him without germline testing olaparib or rucaparib, or you will insist on germline before introducing these drugs?
Ladies first.
Okay, at the moment, it is actually approved only for those with germline mutation. So you cannot give it saying that they have this thing. So it's only for the germline mutation. So you can't give it just without the mutation.
So I put a
Totally
very
agree.
interesting question. Okay, go ahead.
I agree, 100% agree. Makes no sense to give it when no alterations are there.
So, Axel, there is an interesting question for you. Where do you put bicalutamide now?
So, I mean, I know some countries, like even some like patients, like for example in Japan, they tend to have more efficacy with bicalutamide. So really depending, maybe European or patients from the US are different from the genetic profile or whatever from the disease. So I think bicalutamide, I still like to have it because in some men, as said, for example, when you don't have high risk disease, when you have rising PSA in ADT and don't have a PSA doubling time less than 10 months, maybe 20 months, you can work with bicalutamide. There is no harm. Also, I use it when I want to, I have a patient with a rising PSA post prostatectomy and I want to have some mild ADT, not the full window, not the full testosterone suppression, but I want to have an effect on PSA. I want to satisfy the patient. I use bicalutamide as first-line treatment when I just have a rising PSA without evidence of metastatic disease. So it's more PSA cosmetic, but sometimes it is good for the physical and the psychological situation of the patient to reduce the PSA, and you do no harm. But I think it's a step back in the shelf of the treatment armamentarium of metastatic prostate cancer.
So, and what do you use for follow-up your patient, like PSMA PET? How frequently you do PSMA PET?
PSMA PET, I frequently use it in a recurrent patient, for example, to find lymph node which is able to be operated or radiated. Then in metastatic CRPC, PSMA PET is used in some patients, mainly private patients which can afford to pay or where the insurance covers this. PSMA coverage is not for every patient in Germany as of yet because of the evidence there. And in MCRPC, I do imaging every 3 months, only when we have a very stable situation with a PSA less than 5, no clinical signs, no symptoms. I extend this follow-up period to 6 months. And most of the patients are within clinical trials where it's more strict in the follow-up.
I just want to make a comment here.
Yes.
Sometimes you see that, when you do a PSMA scan, the disease is florid, but the PSA has stopped keeping pace with that, it's lagging behind.
Correct.
So does it mean that it's undergoing sort of a neuroendocrine differentiation towards a more aggressive disease? And, these are the places where one could use the platinum?
Yeah. It's a good point. And I think it's again a question for the molecular tumor board. And I would advise, if possible, if you have visible disease, do a biopsy. Have the pathologist to take a look on the tissue and do molecular analysis, and then you can decide. Maybe a platinum is an option. You're right, correct. And we had one of the largest series of carboplatinum treated patients following docetaxel failure. Back at the time when I was in Hannover Medical School, I think about 100 patients we published at ASCO some years ago. So I think there is a role. Unfortunately, carboplatin has no real lobby, no driver, but this is definitely an option.
Madam, the last question to you. What is the side effects of PARP inhibitor?
Well, mainly this, monitoring the blood counts. Because it can cause myelosuppression. So that is one of the side effects. Some issues have been raised about, second malignancies because, you're preventing the DNA repair from occurring. But that is a little contentious issue because, whether it's because the patients have received multiple lines of treatment, they've got AML or MDS, which is like 1 to 2%. Or it is related to the olaparib. So these are, the main side effect is that, and some little bit of GI, but most of the patients, because I have patients of ovarian cancer on the drug, and they're tolerating quite well now.
Okay, ma'am.
Yeah,
Thank you, ma'am. Thank you, Axel, for nice discussion. So we'll go ahead with the now the case discussion.
Thanks a lot. All the best.
Thank
Stay
you.
safe.
Thank you. Yeah, so I'd like to invite my panelist is Dr. Amol Dongre. Is he there? Dr. Amol is there. Then Dr. Vamshi Krishna
Yes,
is
sir,
there.
I'm here.
Yeah. Dr. Raghunath Aditya Pradhan and Dr. Vinita Goyal. We have all 5 panelists, and this is actually they have asked me to discuss 2 cases, but I don't think 2 cases are required because 1 case itself will go through all the aspects of the